From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. So, what keeps you up at night? A growing body of research suggests that people with insomnia are at higher risk of stroke and several other central nervous system diseases. Why is that? And what can people do to try to improve their sleep? Our guest today, Dr. Sonja Schuetz, is an assistant professor of neurology and sleep medicine specialist at the University of Michigan. She was interviewed by Dr. Joe Carerra, vascular neurologist at the University of Michigan, about the protective power of a good night's sleep. Here's Joe.
Sonja, thanks so much for being here and joining us on ANA Investigates.
Pleasure. Thank you so much for having me.
I've found insomnia personally to be something I hear a lot from my patients in clinic. I'm curious if you could share with us the general prevalence of insomnia in the United States and what some of the risk factors might be for developing insomnia.
Sure. Insomnia is one of the most common sleep disorders. And the current studies show that the prevalence of chronic insomnia in adults is around 10%, but that approximately 1 out of 3 adults have intermittent or transient insomnia. Now, the difference between transient or chronic insomnia is whether or not the duration is 1 and 3 months based on our current diagnostic criteria. But there are other criteria that are important. So insomnia for us consists of nighttime symptoms, daytime symptoms, but also includes the fact that these symptoms are not better explained by other causes. When I say nighttime symptoms in adults, that's most commonly difficulties falling asleep, difficulties maintaining sleep, or early morning awakenings. Daytime symptoms can be things like daytime sleepiness or fatigue, problems with attention, concentration, memory, reduced energy, reduced motivation, or even mood changes like feeling depressed or irritable. It is important that these symptoms are not explained by other medical conditions, by other sleep disorders, mental disorders, medications, substance use, or by lack of opportunity to sleep because there's not enough time. For example, a person that works 2 jobs who takes care of your relatives. These symptoms for diagnostic purposes have to be present at least 3 nights per week and lead to disruption in daytime function. Now, in terms of risk factors for insomnia, it's actually interesting that the most widely used model to explain how insomnia develops is more than 30 years old. It's called the 3P model. And the 3P stand for predisposing, precipitating, and perpetuating factors. So predisposing factors for insomnia are things that increase the risk of insomnia, such as a history of anxiety or depression. And they may also be a genetic component here, although the exact genes or how they work together still remain to be identified. Precipitating factors are events that cause sleep disruption, like major life events, whether they be positive or negative, like a wedding, a job change, a move, the loss of a loved one. Those are all events that can trigger an episode of insomnia that can be perpetuated by habits that foster insomnia.
Gotcha. So clearly insomnia is something that's quite widespread and has a lot of potential contributors. I think an important publication that recently garnered quite a bit of interest in the field, entitled Sleep Patterns and the Risk of Acute Stroke by McCarthy et al., was published in Neurology earlier this year. Briefly, they looked at sleep symptoms within the Interstroke International Case Control population and examined associations between a variety of sleep factors and stroke risk. And I was wondering if you'd be willing to share a summary of their main findings and the implications of those findings for us.
This is really a fascinating study. From my perspective, what made it so interesting is that there were so many sleep symptoms that were associated with higher odds of stroke, even after adjustment for many confounders. The strongest association were between short sleep, which they define as less than 5 hours of sleep per night, long sleep, which they define as more than 9 hours of sleep per night, and then breathing cessation. For each of these 3 symptoms or signs, short sleep, long sleep, and breathing cessation, there was a twofold higher odds of stroke. The implications from my side are that sleep disturbances are common and that they're associated with increased odds of stroke, which for me raises the question of a causal relationship between the two. And with that, is there a possibility of a targeted intervention to prevent stroke?
I think that's a really excellent summary. And, you touched on this already, but I think in reviewing the results, the things that stood out to me, not particularly surprised by the association between symptoms like snoring and breathing cessation being associated with stroke, given the fact that there's a pretty established link between obstructive sleep apnea and stroke. Rather, I was pretty surprised by the association they found between short sleep duration, which you noted was defined as less than 5 hours of sleep, and stroke, as well as the association they found between long sleep duration, so as you mentioned, defined as more than 9 hours of sleep nightly, and stroke. In looking at the magnitude of the effect estimates, like you said, both of those were in line and as robust as those reported for a high sleep apnea score. And that was a pretty surprising result to me. Can you potentially share any insights into potential mechanisms driving the association between sleep duration and stroke risk?
Yeah, that's a really interesting question. I think the first one that comes to my mind and that I would like to see an answer to is whether this is a causal relationship or whether short sleep or long sleep are just markers of an underlying process that explains this association. It could be a causal link. There is some evidence in animal models, but also in humans. Sleep deprivation can lead to increased expression of inflammatory markers, can promote oxidative stress, and it's plausible to think that these changes may lead to increased risk of atherosclerosis and cardiovascular disease as a consequence. The other possible explanation is that short sleep is a marker of another disease process, and the one that comes to my mind is sleep apnea because it's so common. And sleep apnea often leads to sleep disruption and to difficulties falling asleep and staying asleep, and it might actually be the presenting symptom of sleep apnea in some patients. For long sleep, I'm not sure that I have a very good explanation. We know there is an increased risk or higher mortality associated with long sleep, but I think the mechanism here is really unclear. Some think it might be linked to depression, maybe as a confounder or as a causal intermediate factor, but I think this is still an area of research.
Excellent. So obviously an area that future investigation might be able to help tease out which factors are confounders, which are actually associated in the causal pathway, as you mentioned. In the study, participants all self-reported on sleep behaviors over the month leading up to enrollment. And I'm curious if we have any data on the validity of self-reported sleep measures.
Yeah, there is data, and I think the overwhelming evidence shows that the agreement is not great between objective sleep measures and subjective sleep measures. Even in healthy volunteers, there's at best a modest correlation between sleep diaries and objective sleep measures. And in insomnia in particular, insomniacs tend to underestimate the hours of sleep or sleep duration. We see that quite frequently in our clinic when patients had a sleep study. They come back and say, I didn't sleep at all. You didn't learn anything about me. And then we can show them, well, based on your brain waves, you did actually sleep several hours. So sleep state misperception might play a role here.
Yeah, and with that in mind, obviously recall bias being a concern, potentially underestimates of sleep duration being a concern amongst folks with insomnia. Are there potentially better tools available to us that will help us to examine sleep disturbances with better validity in future studies?
Yeah, so there definitely are, and they're coming more and more on the market. Wearable devices have been used for a long time in clinical research world, and the one most commonly used is actigraphy, which uses light and movement to estimate sleep duration. There's also a growing market of consumer sleep technology, especially in the past decade. And there are many devices like rings, watches, wristbands. It's not always clear how good these devices are, even though there is a growing literature on these devices. But it's quite limited and there are a lot of unknowns.
So a lot happening behind the scenes, I guess, for some of those devices. Hopefully a little bit will be clarified in the years to come. To pivot a little bit away from stroke, do we have any idea of the associations between insomnia and neurologic conditions outside of stroke?
Definitely. Not just in the neurologic world, but also other cardiovascular disorders like hypertension or heart attacks. Sleep deprivation is associated with a higher risk of obesity. But within the world of neurology, the strongest association is probably with neurodegenerative disorders. And there are several studies that show significantly higher risk of dementia in individuals with insomnia. The increase in risk might be as high as 30 or even 50%. And there's really fascinating research from Dr. Holtzman, Dr. Niederwärts, Dr. Rosorios, and many other groups that show how sleep disruption leads to increased tau and A beta levels, not just in animals, but also in humans. And conversely, that tau and A beta levels decrease during sleep. I think the next step would really be to determine whether sleeping more or sleeping better decreases the risk of developing dementia or any other neurodegenerative disorder like Alzheimer's disease, but that has not been studied yet.
So again, a lot to hopefully learn in the years to come. I think clearly associations between insomnia and sleep disorders and a number of neurologic conditions, as you outlined. Given these findings, I think the big question then is, what do we do as neurologists to potentially address these sleep disturbances? And if you could give us a broad overview of some of the therapeutic options that exist in management and if there's any data driving the quality of those interventions for us.
Yeah, I think the first step should always be to make sure that there's no other underlying disorders that explain the sleep disruption. Sleep apnea is by far the most common, but pain, anxiety, depression, restless leg syndromes, they often play a role and need to be addressed separately for better sleep. With regards to specific interventions for insomnia, there's cognitive behavioral therapy for insomnia, CBTI. It's really the preferred first-line therapy for chronic insomnia in most patients. It addresses thoughts and beliefs about sleep and habits and behaviors. So, for example, the behavioral component of cognitive behavioral therapy for insomnia includes things like establishing a stable and consistent sleep-wake schedule, reduce the time that a person spends awake in bed, avoid naps during the day, and really optimize the sleep environment. Cognitive portion of this addresses anxiousness, ruminating thoughts that are triggered by sleeplessness, inappropriate expectations about sleep hours, but it can also teach a person relaxation exercises. CBTI is superior to medications alone. That has been shown repeatedly in randomized controlled trials, both in terms of subjective and objective sleep outcome. So it can increase sleep duration overnight, and it's been shown to be effective over several months or longer, whereas pharmacologic agents are generally not recommended for long-term use and often lose their effectiveness over time. However, we use them in our clinical practice, and there are multiple FDA-approved medication classes that have different mechanisms of action. For example, melatonin receptor agonists, oral orexin receptor antagonists, antihistamines, or benzodiazepine receptor agonists. And the choice here between these different groups of medications depends on the patient, on comorbidities, on age, on the type of insomnia complaint, and then on the side effect and interactions with other medications.
And so certainly a lot to think about as we potentially address these symptoms in our patients. With regard to cognitive behavioral therapy, CBT, how easy is that to try and actually get our patients connected with?
It depends where you practice, I would say. We definitely need more individuals qualified to conduct cognitive behavioral therapy. We are lucky here at the University of Michigan where we have a large and excellent group of therapists. But outside of here, it can be difficult to refer a person depending on the geographic location, although with telemedicine, access has certainly improved. And there are also online tools and apps that have been studied that are effective to treat insomnia and that are based on cognitive behavioral therapy.
Excellent. And Sonja, hearing you talk about the potential therapeutics and some of the symptoms that people experience, the racing thoughts, the ruminating thoughts, things like that, I know those are some things that I've experienced personally. I'm curious, as somebody who does research in the field, if there are some strategies that you've adopted that are evidence-based to help improve and maximize your sleep.
For sure, yeah. And I think it's something that I've learned more and more over time how important it is to prioritize sleep. So really striving to keep a consistent schedule as much as I can on weekdays and weekends. And also to allow time to wind down before bed, where I turn off, well, I don't turn it off, but I put my phone away and mute any non-urgent alerts. That's something that is really important in our time and age, where a lot of people struggling to turn electronics off at night. We are in a 24/7 society. A TV in a bedroom can often be detrimental. It emits a lot of blue light and is slightly entertaining and just alerting enough to keep people going and going longer than they want. The other factor that I often encounter in my clinic is that caffeine can be quite disruptive to sleep. So we usually recommend to stop drinking caffeine several hours before bedtime. And to avoid alcohol too close to bed, because alcohol can make people tired, but later in the night leads to sleep disruption.
Sonja, those are a lot of great tips. Looking forward at future research, future investigations in the field, I know that the NIH-funded Sleep Smart studies investigating appropriate management of OSA with CPAP as a secondary stroke prevention intervention. A really interesting wrinkle in that study, I think, is the fact that they're also investigating use of CPAP in those with OSA as a rehabilitation intervention as measured by the modified Rankin scale. For junior investigators in the field, what are other similarly important questions that might be ripe for study?
I mean, for me, I would really love to know whether sleep apnea treatment has a role in primary stroke prevention. I think there's a lot of good data from observational study, for example, the Sleep Heart Health study and others, that show that there's an association between untreated, moderate or severe sleep apnea and incident stroke. But we still don't know for sure whether this is cause and effect and whether this stroke onset can be prevented with OSA treatment. So I think that is one big topic in that area. Apart from that, I do think that wearable technology is going to have a big role in sleep medicine in the future, and perhaps in general in medicine. It can provide a lot of objective data over long periods of time. And in our field in particular, it can help investigate patterns of sleep disruption, but also patterns of healthy sleep, and perhaps develop targeted intervention to improve sleep quality and quantity. And that gets me to the next point. I think the other intriguing question in our field is, what is sleep quality rather than just quantity? How do we best measure it? And what is the role of sleep quality in health and disease? So we're just beginning to explore this whole area of research. And so we're in exciting times, and I'm positive that we will see major discoveries and innovation in the next decade.
Excellent. A lot to look forward to in the years to come. Thanks so much for joining us. I think it was a really fascinating conversation about the intersections between sleep and neurologic disease.
Thank you so much for having me.
That was Dr. Sonja Schuetz, interviewed by Dr. Joe Carerra, both of the University of Michigan. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Megan Ritchie. I'm Adeline Goss, podcast host and executive producer. Our program was produced today by Joe Carerra, Caitlin White, and me, with help from Jen Hurley and Michelle Johansson. You can listen to past episodes of the show, subscribe to the show so you never miss an episode, and access all of the ANA's educational programs on the Education tab at myana.org. That's it for ANA Investigates. See you next month.